And here is your question. All right. So if you have read and understood, considering this surgical pathology station, kindly tell me, after reading the scenario, what are the differential diagnoses that you will consider for this particular patient?
My differential diagnosis for this case would be infective endocarditis or also rheumatic heart disease.
Yes.
It could be a viral infection,
Yes.
or it could be a respiratory tract infection such as pneumonia.
All right. Considering infective endocarditis, how would you establish your diagnosis? What are, in other words, what is the criteria?
The criteria for diagnosis are Duke's criteria, where
Yes.
two major criteria or one major and two minor criteria if present are diagnostic.
Or
the major criteria
three minor?
Or three minor criteria.
Yes, one major and three minor, or one major and five minor. Okay. How, yes, if you are taking the blood culture, how would you expect it to be?
The blood culture should be positive, two samples taken 12 hours apart.
Yes.
Or three samples taken 1 hour apart.
Very good. What about, what would you see if you have done the echocardiogram?
On echocardiogram, there will be signs of regurgitation, valvular regurgitation, and then there can be vegetations, and there can be intracardiac abscess.
Yes. What about the valve? Yes.
Ma'am?
Valves, how would they appear?
There will be vegetations on the valves, which are irregular nodules, and valvular thickening and
yes,
irregularity will be seen.
Would be seen. Okay. Can you tell me, if you'll do the blood culture, you've already told me that. All right, sorry. What are the organisms I wanted to ask you that you find commonly?
The common organisms are Staphylococcus, coagulase negative Staphylococcus, Streptococcus, and Enterococcus, and HACCP group of organisms.
If I ask you to tell me the types of endocarditis, can you please name few?
Yes, there is infective endocarditis, then there is non-infective thrombotic endocarditis,
yes,
and Liebman-Sachs endocarditis.
Very good.
These are the types.
Can you please tell me, if a patient comes to you, what are the signs that you look out for, which will point out to be, yes, infective endocarditis?
In the hands, we can look for Janeway lesions, Osler's nodes, which are painful.
What are the Janeway lesions? Can you please?
Janeway lesions are reddish lesions on the palms of the hand, which are painless, ma'am, which are due to
nodular, yes,
due to immune complex deposition.
And what
on
are Osler's? Yes.
Osler's nodes are micro abscesses which are formed due to septic emboli.
They are also red, but they are painful. All right. What are splinter hemorrhages? What do they signify?
Splinter hemorrhages are micro hemorrhages in the nail bed.
All right. Okay. There are two. What are the types? You've already told me, like, what are the risk factors for endocarditis? How can it be prevented?
The risk factors for endocarditis are any congenital heart disease, cyanotic heart diseases, then rheumatic heart disease, then IV drug abuse, and any sepsis in the body, bacteremia,
Yes.
Mechanical heart valves, and
All right.
HIV, diabetes.
If you fail to manage your patient, what are the complications that you should expect for?
The complications can be cardiac complications or non-cardiac complications, ma'am. The cardiac complications can be the septic emboli, intracardiac abscess, arrhythmias, and congestive cardiac failure. The non-cardiac complications can be glomerulonephritis
Yes.
and
Acute kidney injury, stroke, etc.
splenic infarct. Yes, yes.
How should a patient with infective endocarditis managed? What is ultimate management?
We manage the patient with intravenous antibiotics, usually ceftriaxone and vancomycin.
According to the
according to
NHS
the blood
guidelines,
culture.
yes, or trust guidelines, yes, and
later, if the patient does not respond to this,
yes,
IV
what are the
antibiotics is the
one, okay, but you've already told me on findings on echocardiogram, patient is undergoing regurgitations. So what would be and patient has not responded only on medication, they are vegetation. So what would you do? Surgery. So what is
the valve replacement, replacement, or
yes.
also we can go for cardiac transplantation.
Oh, yeah, that's the end result. But what would you consider when you're doing the valve replacement surgery or procedure?
We can consider either a artificial valve or a biological valve, ma'am.
What is artificial? Metallic, you mean?
Metallic
Biological or
and
the metallic? Okay.
yes.
So, yes, sometimes what happens, you have placed the prosthetic valve and patient comes back again with the prosthetic valve endocarditis. So can you tell me, in that case, what is the most common organism in the early days?
I do not know, ma'am. Can I come back to
early like prosthetic valve endocarditis can also be divided into two, early and late. This is less than 60 days is early, greater than 60 days is late. So Staphylococcus aureus, S. aureus, is the most common.
Okay.
And
Okay.
streptococci, that is for the late one. How would you, yes, whereas in case of native valve endocarditis, what is the most common organism that you'll come across?
Streptococci.
Streptococci, very good. Okay, right. What blood test can you do in order to monitor the progress of the disease? One simple. CRP and
ESR
blood
and CRP,
cultures
inflammatory
and blood
culture.
cultures.
Yes.
All right. Okay. If a patient is young, like this lady, and presents with endocarditis has affected her tricuspid valve, what are the consequences?
If the patient is young, then it might be due to intravenous drug abuse affecting the right-sided heart valves. And
patient, yes. What are the consequences if the patient like this one is young, does not have to be drug user, but it has affected the tricuspid valves? So how would the patient present?
The patient might develop symptoms of right side tricuspid regurgitation or tricuspid regurgitation symptoms. Patient might
right heart failure. Okay. Can you, okay, one suggestion that you said that if patient fails to respond to measures like IV, yes, medications and then surgery, and you have to opt for the heart transplant option. So what would you consider? What is the most important thing that
HLA matching
HLA
should be done.
HLA, yes, HLA antigen matching, yes. If HLA antigen is not matched, then what would happen?
Then there is chance of rejection.
Graft
rejection of the
rejection.
graft, type 1
Very
graft
good.
rejection.
Very good. All right. One last question. When there is a rejection of graft, chances increases. So what do you understand by the term hyperacute and acute rejection?
Hyperacute rejection is the rejection which occurs on the table during the transplantation, whereas acute rejection it occurs in less than 6 weeks.
All right,
It's
good.
in-
Right. This is a young patient. You've replaced the valve. What measures would you take care afterwards?
Following a mechanical valve placement,
Yes.
we should
Yes.
go for this anticoagulant therapy
Yes.
to prevent
Yes.
thromboembolism.
Yes.
Where initially we can start with heparin and convert to oral warfarin.
Warfarin. Very good. So, which blood test would you and how frequently
Uh,
would you check for INR?
INR
Yes.
should be done and should be maintained between 2 to 3,
Yes.
and
Very good.
fre-
How frequently?
frequency I don't know, man.
Okay. How frequently would you do?
2 to 3 weeks.
When is regular? How frequently would you call your patient?
I don't know, man. This was not
Really?
given in the
All right. Thank you.